My name is Amy Kepczynski. I'm a professor of law here at Yale, as well as the co-director of the Global Health Justice Partnership and the co-chair of the Global Health Studies program. So before I introduce Professor João Biehl, I wanted to extend thanks to the event organizers, particularly Poonam and Jamie, who've done enormous amounts to make this happen, as well as the sponsors, so the Yale Global Health Studies program, the Global Health Justice Partnership, also our many co-sponsors, including the Yale Council on Latin American and Iberian Studies, Yale Anthropology Department, the Shell Center for International Human Rights, the Yale School of Public Health Department of Social and Behavioral Sciences, the Sociology Department, and the Solomon Center for the Health, Law, and Policy, as well as the Oscar M. Ribhausen Fund at the Yale Law School. All of whom helped support this event. The structure is that we'll have a talk by João, and then Q&A with the audience, and then a reception from 6 to 7, where we'll have the chance to talk a bit more informally. So we're just thrilled to have João here tonight with us as part of the Global Health Studies program inaugural Health Justice Speaker Series. Our series aims to bring to campus scholars who expand and deepen our conceptions of global health, and particularly in interdisciplinary fashion. And that's precisely what João's illuminating and bold body of work does, spanning disciplines, geographies, issues, methods, and approaches. So he is the Susan Dodd Brown Professor of Anthropology and Faculty Associate of the Woodrow Wilson School of Public and International Affairs at Princeton University, as well as the co-director of the Global Health Program, notice another undergraduate global health program, and of the Brazil lab at Princeton. He holds a doctorate in anthropology from Berkeley and a doctorate in religion from the Graduate Theological Union. As you can tell from the diverse set of groups who co-sponsored this event, his work has influenced multiple disciplines and ideas because it is in deep ways cross-cutting and innovative. His research and teaching centers on medical anthropology, the social studies of science and technology, global health, pharmaceuticals, religion and society, and broadly, ethnography, critical theory, and I would say maybe contemporary subjectivity. In recent years, he has authored Vida, A Life in a Zone of Social Abandonment, and Will to Live, AIDS Therapies and the Politics of Survival. Both are award-winning books and excellent ethnographic studies that explore the new geographies of access and marginalization that have emerged alongside pharmaceutical globalization. He's also co-authored When People Come First, Critical Studies in Global Health and Subjectivity, Ethnographic Investigations, as well as the book series Critical Global Health at Duke University Press. One of the things that I find so impressive about his work is, in fact, its ability to move across disciplines in a way that allows him both to do work that's thought of, I think, by people inside of his discipline and who are not as cross-disciplinary as he, as the best version of that discipline, and who also writes papers of the sort that somebody who's a law professor reads with the same amount of enthusiasm and appreciation. So that kind of interdisciplinary work is extraordinarily rare. I've just had the sense from our conversations that part of what is so enables that kind of interdisciplinary work is an incredible generosity of spirit that you have towards other disciplines. Just this afternoon, he talked with admiration about engineers and economists and social scientists and even maybe lawyers. So I think that is part of what makes the work so lively and so important across so many disciplines is its depth of engagement and its generosity, in fact, as well as its intellectual seriousness. I would say, this is work that brings also a characteristic, both critical and holistic and people-centered approach to global health, a field that is not, for all of its attempt at protecting humans, always very people-centered. He cares deeply about the real persons and places in which he works, and for those of us who are invested in global health, I think there's an enormous amount to be learned from his approach as well as the great body of work that he's built up. As you know, tonight he'll be speaking with us about the judicialization of the right to health in Brazil, Enacting Magical Legalism and Prospecting Biopolitical Futurity. So it is an honor and a pleasure to have you here. Please join me in welcoming our speaker.
Thank you. Okay. Hello, everyone. Thank you, Amy, for the kind introduction and warm welcome. It's a great pleasure to be here. I want to thank Amy, Greg, Ali, and Jamie for the invitation, and the staff of the Global Health Studies Program and the Jackson Institute for their incredible help, as well as the Department of Anthropology and the other co-sponsors of this event. I like to think of the social sciences as always beginning in the middle way, and that each one of our ventures is a new beginning. As T.S. Eliot would put it, a raid on the inarticulate. For us, there's only the trying. This trying is for sure a plural undertaking. The work I'm going to share with you springs from pressing complex socio-medical legal realities, and it only took some scholarly form with the aid of multiple local stakeholders in Brazil and a most wonderful and truly interdisciplinary and multi-method research team, particularly the epidemiologist João Biehl, who has worked for Human Rights Watch and is now a professor in the School of Public Health at Yale University, the physician and health policy scholar Mariana Socal, assistant scientist at Johns Hopkins University, the anthropologist and science studies scholar Adriana Petrina, a professor at the University of Pennsylvania, and the wonderful photographer Torben Eskerud, and the activist and scholar Deborah Diniz. And I will be showing some images by both Torben and Deborah throughout my presentation. This is very much work in progress. I look forward to your comments and questions. So let me begin. Across the Americas, we live in exhausted worlds. Worlds on the edge of autocracy, of financial collapse, of infrastructural breakdown, and environmental tipping points, mediated by extreme populism and efforts to dismantle piecemeal, though meaningful, agendas of socioeconomic rights along the enduring violence and deadly health disparities, realities that are time and again couched in a rhetoric of recovery, even as conditions stagnate or worsen. Meanwhile, experts claim to represent reality with more and more modeling, opaque measurements, and faulty predictions, which are all too often oversimplifying and depoliticizing. Where in these polls, models, trials, and projections is there room for the plasticity of social worlds, for the contingent political decision or legal swerve, the unexpected mobilization or flight that sets history and people on an unforeseen course? And how, amid today's alarming global political shifts, can we account for the destructive and violent potentials of people's plastic power, shaped as much by fear and resentment as by need and desire? What kinds of social science, what sort of theory, what kinds of ethical, political, and affective commitments can proffer a plumb line of sorts when the anchors of truth seem seriously adrift? Scholarly diagnosis of the present moment can convey a sense of dwindling possibilities. In Undoing the Demos, political theorist Wendy Brown argues that the encroachment of neoliberalism into all spheres of life is destroying democracy and the broader political realm. Her assessment is bleak. Quote, "Neoliberalism is the rationality through which capitalism finally swallows humanity." In Cruel Optimism, critical theorist Lauren Berlant highlights the fraying of the so-called normative good life of American late liberal capitalism that promised upward mobility, stability, intimacy, and equality for all. For Berlant, desire and the possibility of imagining alternative futures are somehow already in the service of or only thinkable within the logics of failed social systems. Yet, might even the cruelest of optimisms open onto something else? In the past 2 decades, my major ethnographic projects, as Amy mentioned, have explored the new geographies of rights and abandonment that have emerged alongside pharmaceutical globalization in a restructuring Brazil, particularly around HIV/AIDS and mental illness. A major player in the political economy of pharmaceuticals in the Global South and boasting a universal healthcare system, Brazil offered fertile ground for thinking through the unanticipated ways people mobilize for treatment from the government and the market in context of stark inequality. As afflicted individuals and makeshift communities scavenge for resources and care, they find themselves entangled in novel biomedical and pharmaceutical rationalities and in altered forms of common sense amid the growing tension between health as a public or private good and the reconceptualization of care as a technological intervention rather than a relational practice. From this ethnographic sensorium, one comes to understand economic globalization, state and medical reforms, and the acceleration of claims to human rights, how they coincide with and impinge on a local production of social death. One also comes to discern a distinct sense of grassroots politics in which peoples, let's keep them plural, devise social relations, mobilize their wants, and find legal means of holding states locally accountable, thus creating alternative capacities in the meantime of a struggle, as I like to call it, amid dire infrastructural conditions. Meanwhile, Brazil has experienced a de-alignment between its major political parties and society. Exacerbated by social media, this process has enhanced the power of populist rhetoric and authoritarian drives to hijack electoral politics, as we saw in the recent presidential election of the former army captain Jair Bolsonaro. While people-powered action might not produce a grand new utopia or the direct means for a systemic alternative, local mobilizations for progressive policies and the capitalization of opportunities, even in conservative and polarizing scenarios, nonetheless speaks to a distinct sense of politics in the making and of an ongoing democratization of society, even alongside a resurgent authoritarianism. We know that we will lose, but we will keep trying. Paola Bergallo, a professor of law and an attorney with the Center for Law and Social Transformation in Buenos Aires, stated at a conference in Princeton on reproductive health politics last spring. Bergallo, who is currently a visiting fellow at Yale, was speaking of her team's efforts, along with the hundreds of thousands of Argentinian women who have taken to the streets and the courts in recent years to raise awareness about domestic violence and to press for stronger laws to protect women, as well as for the legalization of abortion. While the justiciability of socioeconomic rights is of increasing interest internationally, nowhere it is more pronounced than around health in Latin America, a region marked by pervasive unrule of law, and that in the past 3 decades witnessed the ratification of democratic constitutions with a whole range of human rights commitments. My current research addresses the meeting points of medicine and law in Brazil. In 1988, the People's Constitution of 1988, as it was called, declared health as the right of all persons and the duty of the state. And the creation of the country's universal healthcare system, called SUS, extended free health coverage to all citizens. Since the early 2000s, in the wake of a successful universal AIDS treatment policy that put Brazil in the international spotlight, a growing number of citizens have been seeking and sometimes realizing access to treatment through the courts, a phenomenon that has been termed the judicialization of the right to health. Though individual patients and patient associations are suing the government for everything from baby formula to complex surgeries, a large portion of lawsuits are for access to medicines. With the increasing number of cases has come controversy over the phenomenon and its consequences. Contrary to claims by public officials and the media, the judicialization is driven primarily by urban elites and private interests. In my ethnographic study, I found that right to health litigation is in fact a widespread practice accessible even to the very poor. This judicialization of health unfolds in a landscape of widespread dissatisfaction with the overworked healthcare system. As Brazil's current meltdown shows, state resources are being used and depleted to shore up particular political projects and interests, A national survey in 2014, at the peak of anti-corruption outcries and anti-Workers' Party public demonstrations, showed that an overwhelming 45% of Brazilians listed health as the country's principal concern. I'm thus interested in how people work through available legal mechanisms and the judiciary to claim access to medical technologies and care when states' mechanisms fail them. That zone where medicine and law intersect in unexpected and deeply personal ways, and where our notions of how medicalization and biopolitics operate from the bottom up must be rethought. Paula Bergallo and other new jurisgenerative communities are seizing on the changing role of legality and the expanding political role of the judiciary in the region to press for systemic change in the advancement of women's reproductive rights. They stand for a creative political shift in the shift, Bergallo's words, in how human rights have entered constitutional deliberation in democratizing Latin America. For Bergallo, a homegrown and gendered form of human rights, constitutionalism, is now in order. While the immediate efficacy of these efforts at feminist legal reconceptualization and jurisprudence still awaits empirical assessment, Bergallo counters criticisms of futility with a longue durée imaginative approach. We are doing magical legalism, she says. And when the political opportunity arises, and it can even be in conservative times, we will have our weapons in place. In rejecting a sense of deadening bleakness, Bergallo casts present-day feminist legal activism as part and parcel of an imperfect form of politics, which she theorizes as akin to magical realism, the chiefly Latin American narrative strategy characterized by the matter-of-fact inclusion of fantastic elements into seemingly realistic fiction, and which found its canonical incarnation in Gabriel Garcia Marquez's classic 100 Years of Solitude, where lived time is certainly not reducible to clock time. Insisting upon action, even amid an incongruous political present, Bergallo's magical legalism holds open possibilities for a future otherwise. In the past few decades, the law has indeed been a favored mode of action in countries transitioning from military to democratic regimes, with an international human rights system playing a key role in that liberalizing. Anthropologists such as Sally Engelmary have shown that, quote, the existence of a transcendent system of human rights, even vaguely defined, gave strength to local demands for justice. Mark Goodale and Nancy Postero have argued that the judicial contestation of governance that accompanied neoliberal reforms in Latin America, it speaks to, quote, new ideological landscapes and alternative frameworks for social change, that is, new horizons of possibility. Bergallo and comrades do not subscribe to the notion that we are now facing the end of human rights. Given the shift in the global balance of power from governments committed to human rights norms and toward those indifferent or actively hostile to them, as David Reeve recently noted in Foreign Policy. It is in the creative tinkering with the earlier constitutional incorporation of universal human rights that this new generation of legal activists is crafting a magical legalism that affirms and otherwise to the constraining limits of their here and now. In doing so, they create the conditions of political futurity. The current experience of Venezuelan migrants in Brazil and Colombia is a most telling example of how vital the constitutional right to health can be. Both countries have recognized, if imperfectly, their obligations to ensure access to care for the tens of thousands of migrants crossing their borders from Venezuela daily, facing malnutrition, chronic conditions, and infectious diseases, a stark contrast to the rhetoric and reality in the United States. What is extraordinary in the jurisgenerative work of Bergallo and colleagues, and in the widespread right to health litigation that I have been chronicling, is that these practices allow for the entry of diverse voices in public debates about the object and scope of the right to health, the nature of care through and beyond technology, and the public-private interface in contemporary governmental institutions. The judicialization of health and of other socioeconomic rights is not seamless. It is a heterogeneous phenomenon that compels vulnerable peoples, laws, experts, officials, and medical technologies to shuttle between home, hospital, public offices, streets, and courtrooms, remaking those spaces and themselves. This peopling of technologies and related judicial plasticity is thus a key lens for us to identify emergent forms of people-powered action within preposterous social orders and lopsided politicking. Let me place these questions, if only cursorily, in historical perspective. Two concurrent and paradoxical trends inform the structure of Brazil's universal healthcare system. On the one hand, there was a trend toward a greater recognition of the role of government in the fulfillment of social rights in democratizing Brazil. On the other hand, a neoliberal theory of government emphasized decentralization and outsourcing of state functions to the private sector. While the federal government assumed a central role in public healthcare funding, regional and municipal health departments had to develop new structures to assess health needs and to manage funds for the delivery of care. This arrangement produced a delegation of responsibility without ensuring funding compliance or technical capacity for implementation. Thus, although Brazil today has highly progressive health policy, many people go to public pharmacies only to find that essential medicines are out of stock and that newer medicines that they seek are not included in outdated drug formularies. In practice, governments at all levels have not been able to effectively manage a complex healthcare system under increasing technological, infrastructural, and economic demands from the public and private sectors, which themselves are becoming increasingly indistinguishable. As I documented in the book Will to Live, Its Therapies and the Politics of Survival, in the mid-1990s, Brazil became the first developing country to universalize access to antiretroviral therapies, about 5 years before global policy discussions moved from a framework that focused solely on prevention to one that incorporated universal treatment, a breakthrough made possible by an unexpected alliance of activists, government reformers, public science, development agencies, and the pharmaceutical industry. If Brazil's AIDS policy was at once a significant accomplishment and unevenly successful, the politics of its development and consequences continue to play out in the country today. AIDS activists were among the first to successfully equate Brazil's constitutional right to health with access to pharmaceuticals. And in the following years, this right-based demand for treatment access migrated to other diseases. People of all social backgrounds started to file lawsuits to access medicines. A ruling by the Supreme Court in 2000 concerning a patient's access to a newer antiretroviral drug described the AIDS Pharmaceutical Assistance Program as the actualization of the government's duty to implement programmatic norms that secure the health of the population. With such programs, as Justice Celso de Mello argued, the right to health ceases to be, quote, an inconsequential constitutional promise. What we are now seeing in Brazil is a biomedical and legal shift in the ways health issues are conceptualized and addressed. In terms of both delivery and demand, public health is now understood less as prevention and primary care and more as individual access to medicines and community outsourced care. That is, public health has become increasingly pharmaceuticalized and privatized. In the process, the country is becoming a profitable platform of global medicine with one of the fastest growing pharmaceutical markets in the world. It is estimated that about 50% of the adult population uses pharmaceuticals on a continuous basis. The idea of pharmaceuticalization builds on and revises the related notion of medicalization, understood as a form of control that obscures the social determinants of health by approaching disease and treatment in exclusively biomedical terms. Medical anthropologists have rightly critiqued the medicalization paradigm for being overly deterministic. While the culture of biomedicine is undeniably powerful, people do not simply become the diagnostic categories applied to them. They inhabit them to greater or lesser degrees. Understanding our present-day pharmaceuticalization of health does require moving beyond the unidirectional construction of patient subjectivity by medical diagnostics and treatments to account for the entanglement of multiple social forms and markets, the chemical concreteness and circulation of pharmaceuticals, and the role of patients' agencies and desires. In the process, the question of what is frugal and essential to health and well-being, what one can do without, and what one has to have to survive, is ever more tangled and contested. Over the last few years, I have been collaborating, as I mentioned, with various researchers in the US and Brazil, developing an ethnographic and a statistical portrait of the people who are turning to right to health litigation, particularly in the southern state of Rio Grande do Sul. With a population of 11 million people, the state has seen a sharp increase in health-related lawsuits, as you can see in this image, rising from over 1,000 new cases in 2002 to over 17,000 new cases in 2009, the period when we started to do this collaborative research. Roughly 70% of these lawsuits were for access to medicines. By 2011, Rio Grande do Sul had the highest number of health-related lawsuits in the country, with more than 100,000 pending cases. Consider Ronilda, who sued the state for medication to treat her pulmonary hypertension. The 50-year-old woman lives with her husband, a taxi driver, in a shanty town in the capital, Porto Alegre, where the couple runs an informal bar in the front portion of their brick shack. Ronilda found out she was HIV positive in 2002. She did not have trouble accessing her high-cost antiretroviral therapies, which she received for free in the local health post. In early 2009, however, Ronilda began feeling out of breath. Unable to perform her duties as a custodian, she lost her job. A doctor at the local health post prescribed her a medication for pulmonary hypertension. Unlike her HIV/AIDS treatment, the medicine was not offered through the public healthcare system, and at the time cost about $1,000 a month to treatment. Following her doctor's advice, Ronilda went to the public defender's office and filed a lawsuit. Welcome to the juridical hospital, said Paula Pinto de Souza, the attorney in charge of right to health litigation in the public defender's office of Porto Alegre. Her office is where the poor, like Ronilda, get free legal assistance and where the majority of the lawsuits requesting medicines from the state originate. Souza did not mince words in describing what she thought the state's biopolitics had become. When there are no defined public policies, or when they exist but are not executed, or when policies are not in touch with new maladies and medical advancements, what do we have? We have a diseased citizen. We are beyond preventative medicine here, and the concept of health as physical, mental, and social well-being is no more, she continued. When this sick person comes to me, the cure is most likely no longer possible. Her right to health has been profoundly injured by public power. A retired bus driver, Edgar was dealing with significant motor difficulties. He had to wait for more than a year for an appointment with a neurologist at a Porto Alegre public hospital. And when he was finally diagnosed with hereditary cerebral ataxia in 2008, Edgar was prescribed the drug Somazina, which is not included in any governmental drug formulary. Raised in a destitute family, Edgar had been working since the age of 8, and he proudly showed me his worker's ID card as a child. He was proud of the gated brick and mortar house he had built himself. While Edgar felt that Somazina was helping to halt the degeneration of his motor abilities, he was also taking other drugs, from statins to antihypertensives to antidepressants, to soothe additional symptoms. At his dining room table, Edgar opened a box containing the 5 medicines that make up his regimen. As he held Each one in turn, he said, this one, I don't judicialize. This one, I don't judicialize. This one, I don't judicialize. I only judicialize this one because I got in debt paying for it. A monthly supply of somazina costs about $200. After paying for the drug out of pocket for several months, Edgar had to take out a bank loan. Unable to keep up with household expenses and the interest on his loan, he said that he had, quote, no alternative but to judicialize, and filed a lawsuit with the help of Souza at the public defender's office. A district judge issued a court injunction on Edgar's behalf, and he received the medicine for several months until the delivery stopped. He then filed a new claim, winning another injunction for 3 additional months of treatment. As for why he was not judicializing the other drugs he was taking, Edgar reasoned, I know that the state cannot give everything to everyone. I have to do my part and pay for whatever I can. The lawsuit is only one part of Edgar's treatment complex, and even the efficacy of his own medication was uncertain. Judicialization is not an attractive option to begin with. Although it saves him money, Edgar must periodically renew the lawsuit with no guarantee that drug delivery will continue. In some sense, Edgar prefers the position of consumer to that of citizen, as it gives him more control and confidence. The market, in this sense, is more reliable than the welfare state. The medicine box is Edgar's survival kit. Yet what does not fit in this box is the psychosocial care, for example, that could help Edgar improve his quality of life as the disease progresses. A lawsuit would not help him gain access to such services. The stories of patient litigants like Ronilda and Edgar illuminate the overlapping subject positions that individuals occupy as they procure precarious access to treatment through the market and the courtroom, balancing clinical needs with shifting boundaries of personal and public responsibility. While examining these tense negotiations of the constitutional right to health in daily life, I often also had a sense that social roles and institutional positions were out of place. The judiciary was acting as a sort of a pharmacy. The public defender as a physician. The physician as an activist. The patient association as legal counsel. The patient citizen was becoming a consumer, and cost-cutting public officers had kidnapped the discourse on equity in their anti-judicialization campaigns. Debates over the whys, hows, and effects of the ever-expanding judicialization of the right to health in Brazil and across Latin America have been marked by polarized arguments and limited information. A majority of judicialization studies have used imperfect data, focused on short-term outcomes, and implicitly or explicitly advocated for its containment and management. Arguing that right to health litigation is disruptive of public health policies and budgets, and that by overruling the autonomy of the bureaucracy, it also reduces efficiency and increases inequality. Individual plaintiffs' demands are presented as the antithesis of a supposed collective need, and actual people, their health-seeking struggles and hopes are nowhere to be found. Wedded to evidence-based public health at all costs, many of these critics also fail to recognize that right to health litigation can be an urgently needed corrective when administrative channels fail people in dire circumstances, and that judicialization can itself be a source of practice-based evidence. To respond to the need for more comprehensive knowledge of the struggle to realize the right to health, our team collected data on lawsuits requesting medicines from the state of Rio Grande do Sul. We accessed the health department's electronic registry, and after selecting a random starting point, we systematically collected every 6th case opened during 2008, the first year this data was available, totalizing 1,262 cases in the sample. Right now, the largest sample in studies of judicialization in Brazil. The results of our research challenge many common assumptions about right to health litigation, offering an empirical counter to widely circulated views. From this localized, people-centered perspective, judicialization emerges as a complex and dynamic element of a faltering health system and as a critical dimension of democratic life. Let me show you some of our results. Of the litigant population we sampled, a little over half were female, and the vast majority, 92%, lived outside the state capital, showing how geographically widespread this phenomenon is. Individuals who judicialized were also predominantly older. While past research has suggested that right to health litigation is for the most part a practice of the financially better off, our findings show this to be false, at least in southern Brazil. Among the plaintiffs who reported their employment status, more than half were either retired or unemployed. Although we do not have direct data on income, about close to 60% of plaintiffs were represented by the Public Defender's Office, which provides free legal assistance only to poor and low-income individuals. About a third of Rio Grande do Sul's 496 municipalities have a Public Defender's Office. And it is likely that this presence increases individuals' access to justice, as well as understandings and expectations of rights at the community level. Our data also found misconceptions, also corrected misconceptions about the character and cost of medications sought. Overall, 73% of plaintiffs requested at least one medicine that was already part of governmental drug formularies. That is, they should have been available in the public healthcare system. 41% of the plaintiffs requested on-formulary medicines exclusively, while 27%, like Ronilda and Edgar, requested off-formulary medicines exclusively. The vast majority of cases, 80%, indicated treatment was requested for a continuous duration, reflecting the chronic character of the diseases that afflict these older, by and large, older patient citizens. The most frequently requested medicines were for common problems, such as asthma, hypertension, cholesterol, and mental illness. They were part, by and large, of official drug formularies and had therapeutic protocols defined by the Ministry of Health. Most patients had comorbidities and required multiple medicines, close to 3 medicines per lawsuit. These results suggest that government pharmaceutical programs are failing to fulfill their role of expanding access and rationalizing use, and that the poor, legally empowered, are trying to make the system redress this failure. Contrary to common assumptions, litigants mostly sought low-cost drugs. Like Edgar, the vast majority, 75%, requested medicines with a monthly cost below $250. You see, for the vast majority of patients, you can see the cost of the lawsuits was here. Of course, there are outliers here, the very expensive genetic therapies and other treatments, right? But the vast majority of patients, and you can see in this image that there was no significant, that high-cost lawsuits composed a minority of the sample, and that overall on and off formulary medicines did not diverge significantly in terms of cost. Just as the majority of plaintiffs requested medicines that were part of governmental drug formularies, a large number of plaintiffs initially tried to secure treatment through local administrative channels, turning to judicialization only when this channel failed. And 85%, as you see in this figure, of lawsuits including a physician-issued prescription or a report confirming the need of treatment, and the great majority were written by doctors from the public health care system. This was the case of 16-year-old Leticia and 9-year-old Caccielli, who live on the outskirts of Porto Alegre. Both sisters suffer from phenylketonuria, or PKU, a metabolic genetic disorder. The difference that the younger sister, Caccielli, was immediately diagnosed and treated with a combination of diet and medication. Leticia, the elder, was not, and now suffers from severe intellectual disability. Leticia was only diagnosed because her sister was born after screening had become mandatory, and the special baby formula needed to prevent the development of the disease had become universally available via the public healthcare system. About 120 patients in the state need this special milk formula. But given distribution problems, 25 families had to file lawsuits to ensure access. We interviewed all litigant families who, for the most part, live in the interior and are very poor. Once, when the government failed to make the formula available, Neri and Marisete, the girls' daughters, told us we also filed a lawsuit. They did so with the support of Dr. Paula Vargas, the girls' beloved physician. As Dr. Vargas said, these patients simply cannot go without treatment. It would be a crime. While waiting for distribution to resume, the caring doctor helped the family to get in touch with other PKU families who in solidarity lent them their own formula. Other families went to local newspapers and radio stations to decry their plight. As one mother told us, nós precisamos entrar na justiça e daí na imprensa. We have to first enter justice or the judiciary and then the media. Strikingly, in almost all of the lawsuits we studied, the judges granted the plaintiffs an immediate injunction demanding the state to provide the requested drugs, explaining this was consistent with Brazil's constitutional obligations to fulfill the right to health. To investigate whether judges took governmental norms for drug provision into consideration, we also analyzed the frequency with which judges ruled on the provision of generics. And here you can see in 76% of the cases, they prescribed generics, and from the sample of lawsuits where there was explicit reference to the drug form. In sum, counter to prevailing anti-judicialization narratives, our results reveal a process of judicialization from below, stemming from low-income and older individuals who do not live in the major metropolitan areas. The local presence of a public defender's office is a key institutional factor driving this grassroots mobilization, as is a responsive judiciary. In a new geospatial analysis that we are now doing, we are finding that municipalities with a public defender's office were 7 times more likely to have a right to health lawsuit than municipalities without a public defender's office, and that municipalities with greater availability of health services had overall a slightly lower number of lawsuits. In addressing a dysfunctional health system that failed to provide for their needs, poor patients face the option of either seeking costly private sector alternatives or voicing concerns through cumbersome participatory mechanisms like community health boards. Our study shows, though, that through right to health litigation, some Brazilian citizens are finding new ways of concretizing voice, as Albert Hirschman would have it, through a process of entrar na justiça, entering justice, acting as political subjects to hold the state accountable and exposing the disastrous realpolitik of executive and legislative bodies. Like attorney Paula Pinto de Souza, Judge Eugênio Terra, who oversees all health-related lawsuits in Porto Alegre, finds that lawsuits are largely filed by poor and desperate patients seeking treatments that should be available in the public system. I'm doing social justice one by one, he told me. When I'm issuing an injunction for cancer treatment provision, I'm also indicting services that have not kept up with people's needs. Our analysis of lawsuits also showed that when patients sought new technologies, not yet included in obsolete benefits packages, the federal government tended to incorporate the requested technologies into official policies later. Among the 20 most frequently requested off-formulary medicines in our sample, 7 have been incorporated into governmental formularies since 2008, including the most expensive one. While in no way a magic bullet for broader structural political problems, judicialization can nonetheless be understood as a significant mechanism of both accountability and responsiveness, highlighting gaps in the health system and sometimes, however modestly, addressing them. The state has evolved in its response to judicialization. Throughout the country, health administrators have started to designate staff and implement software systems to manage court-obtained treatments. New public pharmacies were established to exclusively store and provide judicially obtained treatments, effectively creating parallel delivery systems of judicial and non-judicial drugs within the public health system. General attorney offices have organized task forces focused on health litigation, designating teams to work exclusively on health-related lawsuits. Medical consultants have been brought in to help prepare evidence-based defenses, and because health-related lawsuits inundated courts, specific jurisdictions have been appointed to concentrate these cases. In some cities, mediation courts have been created to resolve claims to medicines before lawsuits even started. Despite these steps, information on judicialization remains restricted. While government officials blame judicialization for disrupting health policies, public administrators often do not release data that would allow an open examination of right to health litigation if it's being conducted by whom and who benefits from it. In some cases, agencies are creating barriers to data access instead of reducing them. This obfuscation matters. Claims about the costs and benefits of judicialization and its relationship to equity in health require analysis of procedural justice as well as human capabilities, and such analysis requires detailed data. In a recent article, my colleagues and I argued for greater data availability and open access, and for extending the focus of judicialization study beyond the claims formation and adjudication stages to its implementation stage and social outcomes. Multi-source, multi-stakeholder mixed method approaches can help us capture the heterogeneity and dynamism of judicialization, and to both understand its actual impact and identify factors that can provide actionable targets to improve policies. Ultimately, we should seek to produce real-time data that can help drive advancement towards transparent and participatory priority setting, as well as accountability mechanisms that promote quality, universal healthcare coverage. I want to conclude with a few comments on the aftermath of the recent Zika epidemic, which speaks to the dynamic evolution of right to health litigation in Brazil. The Zika virus arrived in the country in 2015, and as of now, an estimated 4,000 children have been affected by the congenital syndrome. Even though Zika has been present in the biomedical literature since the 1950s, it was only with the Brazilian outbreak that the effects of the virus on fetal development were identified. As the anthropologist Deborah Diniz puts it, in this story, where a mundane disease of the tropics proved to be a source of tremendous distress for women, the key protagonists were not physicians and scientists, but mothers-to-be. Indeed, the women whose pregnancies were affected by Zika embodied multiple markers of difference. They lived in historically dispossessed and precarious infrastructure areas in the country's poorest northeastern region. They were mostly black, brown, and indigenous, women who lacked regular access to healthcare and information on contraception and family planning. The impact of Zika on these women and their families shows that the right to health is not only individual, but also collective, thus requiring a focus on population health and community interventions. It also reminds us that the right to health is not only the right to treatment, but also the right to prevention, supported by a broad range of social policies. Brazil once effectively controlled the Aedes mosquitoes that carry Zika, as well as dengue and chikungunya virus, but years of neglect allowed their resurgence. Lack of distribution of basic prevention resources and water collection and sanitation systems allowed the mosquitoes to spread. The failure to fulfill the right to health in the case of Zika continues even after transmission has declined, as the health system is unable to provide appropriate and adequate care to babies affected by the Zika syndrome. Meanwhile, widespread outrage over the multiple social and political determinants that fuel the epidemic has created a propitious environment for a renewed debate over reproductive rights and the decriminalization of abortion in Brazil, in line with efforts in neighboring Argentina. Activist groups seized the occasion to decry the fact that highly vulnerable women had to submit to compulsory pregnancy in the face of severe public health emergency. Abortion is basically a right in Brazil, is basically a crime in Brazil. It is only legal in cases of rape, when necessary to save a woman's life or when the fetus suffers anencephaly. Studies estimate that 1 in 5 Brazilian women has had an illegal abortion by the age of 40. Given Brazil's current conservative political scenario, it was not feasible to challenge the criminalization of abortion via Congress, attorney Gabriela Rondon told me. So in August 2016, feminist activists, in alliance with the National Association of Public Defenders, petitioned the Brazilian Supreme Court. Using a comprehensive social rights framework, they requested both individual and collective remedies for those affected by Zika. The demands were simple: access to information and prevention tools, timely attention to health facilities and specialized care, transportation to care centers for babies living in remote areas, and access to family planning, among others. The lawsuit also challenged the criminalization of abortion on the grounds that pregnant women experiencing mental health impacts from contracting the Zika virus during pregnancy should have the option to interrupt the pregnancy. The case has helped reignite a vigorous national debate, with thousands of reports in the media and the PSOL political party filing a separate case challenging the criminalization of abortion in the first 12 weeks of pregnancy. Rather than resorting to the ideas of autonomy or privacy, the team of young feminist attorneys, Gabriela Rondon and Sinara Gumieri, seen here in the photo to my right, they use the constitutional principles of human dignity and of citizenship in their arguments. Given socioeconomic inequalities, white women with higher incomes are able to exercise their self-determination regarding abortion, even in the context of illegality, while poor women are left constrained between extremely unsafe abortion or compulsory maternity. The criminalization of abortion thus intensifies what they call their second-class citizenship. As Rondon recently told me, echoing Paula Bergallo's remark about magical legalism, we believe that there is no preset architecture or roadmap for litigating for reproductive justice. And every new case has represented both continuity and rupture with previous debates and efforts. We need to be ready to be both creative and sensitive to the historical and political moment so that when there is a chance, we can make a social difference. The Supreme Court, which has been consumed by a series of cases on corruption, not to mention the impeachment of President Dilma Rousseff and the arrest of former President Luiz Inácio Lula da Silva, will issue its ruling this coming May. The story of Zika and its activist aftermath raises important questions about what drives judicialization on the ground and the impact of judicialization on a broader understanding of the state's obligation to fulfill the right to health, both individual and collective. What appears superficially as individual vulnerability and demands for care ultimately reflects a collective condition of underlying structural precariousness. Similarly, what appears as an individual response, litigation, can also be seen as a collective movement to press for local and systemic change. Seen from this perspective, judicialization is part of democratic life, something to be understood in its complexity and possibly tinkered with or reoriented so to promote substantive human rights. People refuse to be stratified out of existence, using any means available to poke holes in macro models and population-level calculations that would hold their lives captive or delimit their life chances. The hard to pin down hyphenated subjects like patient, citizens, consumers, introduced throughout this talk, speak to novel forms of social becoming at the interface of medicine and law. Their medical legal trajectories show that politics matters differently to a growing number of sick and vulnerable low and middle income Brazilians and their legal partners, engaged as they are in the plastic and ever-evolving twin phenomena of the pharmaceuticalization and judicialization of health. Litigants may not be establishing an immanent civil society, but they are establishing themselves as people while navigating the vagaries of market inclusion and livability. As part of a reticent and contradictory outer commons, they demand workable infrastructures and become the harbingers of a biopolitical futurity from below. Here, the shape of collectives and the right course of action remain undetermined. Channeling this unmoored social formation, law thus appears as the practical tool of an otherwise. The current moment, after all, calls less for the all-knowing hubris of totalizing analytical schemes than for a human science and politics of the uncertain and the unknown. Thank you for your attention.
Start is sort of, as you sketched out for us, a lot of the debate around judicialization has been through this lens of equity, right? With the critics saying individual cases of this sort, the very poorest can't bring them, and they're driving spending in ways that are contrary to public health priorities, et cetera. And your work very powerfully refutes some of those arguments. I think, obviously, you're only looking at one state and so forth, but you have this very powerful evidence as you walked us through, showing that, in fact, it's not right to think that most of these participants are middle class or privileged. And in fact, the majority seem to not be, both geographically and probably also sort of socioeconomically. And in fact, most of the things they're asking for are things that they're entitled to under the existing programs and so forth. But you don't say one more thing, which might be the more decisive refutation of this argument, which is to say, one of the ways that these cases might be thought to be driving priorities in ways that are inequitable is that it's a very small number of the drugs involved, and in fact, probably a very small number of the litigants that drive a huge amount of the cost. And so I think the last figure that I saw came from around 2011, where it was 80% of the cost come from less than 1% of the litigants, and just 20 drugs, right? And this is because of what we know about pharmaceuticals, which is it's the really new, expensive ones that drive a huge amount of pharmaceutical spending, right? And so you don't really tackle that version. And I wonder whether, in some sense, that might suggest that there could be two truths. One, that in fact the majority of these cases are described by what you are articulating as this kind of imminent experience of citizenship that is in fact forming new kinds of accountability, and that in fact the overall phenomenon has created dynamics that are troubling from a kind of systematic perspective. If they're both true, are they both true? If they're both true, what ought we think about that? Is there one way that we ought to think, what we ought to prioritize is the imminent citizenship and the futurity, the dynamic nature that this enables? What do you do with the public health folks out there who might say, no, what we ought to prioritize is sort of some more solidaristic or collective way of setting priorities, which would let us, let's say, think about everybody and contain costs in the way that we might without these. That's my first question. Maybe I'll just I'll say one more thing. I'll skip one of my other questions. I'll say one more thing. My other question is some of the work that I've done, and largely driven by my simple tracking of what activists in Brazil are doing, is that activists in Brazil, some of the AIDS activists that you mentioned, who sort of started this whole train going, have also brought to the courts cases where they try to say, let's take on the conditions that make these very expensive drugs expensive, let's tackle the patent laws, and let's tackle the prices. And they bring arguments to these courts that in many ways are quite open to claims about the right to health. And they say, well, the government should have to lower the prices. The government should have to buy generic drugs. The government should have to take these structural actions. And the courts don't do it. Courts are quite resistant to the sort of more structural kinds of claims that might, in fact, address, if I'm right about what one critique of it. And so one question is, why are the courts resistant to that? And this is the second question. Does that also tell us something about what's going on in this moment of a kind of new form of citizenship that is in fact maybe more deeply neoliberal than the other phenomenon, or maybe they're both neoliberal, I'm not sure. So I offer those both. And then maybe, do you want to take a few questions from the audience first, or?
You guys, is that okay if I just respond briefly and then we take a few rounds of questions? These are wonderful. Thank you for your generous reading and articulation, further articulation of this phenomenon and some of the key points that I tried to convey. Why do courts resist the state? Oh, sorry. Why do courts resist, the state? So there's really an empowerment of the judiciary, as we could see in Brazil, for good and for bad, right? As a political body, really a strong one. So there is this phenomenon of the judicialization of politics, a larger phenomenon, where the judiciary feels that they are one of the only sites that can hold the legislative and the executive accountable to a certain extent. So that's a larger phenomenon that has been happening in Brazil over the past 2 decades, given the electoral forms of politics, right? Which basically have 4 years in power, and then you have the resources, you don't do anything, and then you use the state resources for re-election, et cetera, et cetera. So the courts do not buy the argument that it's infringing on budgets, because the state has an obligation to deploy a certain percentage of tax collection on the health system, and it doesn't do that. So the argument that it produces inequality for the courts does not hold, because the government is actually not investing as much in health as it should. This is called the reservoir of the possible, or reserve of the possible. So courts are very reluctant. They tend to side at a lower level with the litigants, because they know the way local politics operates. So there's so many dimensions to unpack. I will try to say a few things, and then we collect more questions, and maybe we'll craft a text together here. When we started this project in the late 2009, 2010, there was a dominant narrative. Judicialization produces inequality. And that's an essay that was produced by Octavio Ferraz and other scholars. And when we started to study those studies, they have very fragile evidence. This is an ideological argument that they're making, a point that they're making, a political statement. But the data that was used until then was basically based on a study in São Paulo, based on zip codes, on a neighborhood in São Paulo. And they assumed that this was a middle class, neighborhood. They never thought it could be a maid. So there was not kind of an exploration. It was a very circumscribed and limited. But so a lot of the subsequent studies were really framed to make that point. So we said, no, we first need to understand what the phenomenon is. So that's where we teamed up, got more people involved. We tried to get access to data. But it's interesting, when we started to find these results, our partnership with the state of Rio Grande do Sul broke down. They didn't want us to publicize these results. So this second database that I showed to you today, it took us 2.5 years to get access to. We had done one initial, and we found the same results. So we almost had to judicialize just to be able to get our database, because they were not happy with that narrative. So it was very interesting. So there was this alliance between, by and large, public health research or some ideological political argumentation by legal scholars, right? And that was really was taken up by public officials, who then said, see what's happening, let's not even consider this, right? So in some ways, our job was to try to create like an evidence as robust as possible to try to deconstruct their story. And then when we produced this evidence, then the argument was, oh, but this is an exception. This is the south of Brazil. So the discourse on exceptionalism start to come in. But it's the highest number of cases in the country is in the state of Rio Grande do Sul. There's a history of political activism or judicial activism there as well that can explain parts of that. So the other question so there is something, what the scholars brought to the discussion and the study of judicialization has not been problematized enough. And I think the narrative of equity was so interesting to me, to have then this legal scholars having the same discourse as the very corrupt and conservative officers. So there was something was puzzling to me, And so that lack of reflexivity, I think, is starting to break open now because there are more and more studies taking place which show similar phenomenon as in the south of Brazil with its own variation throughout the country. The question that you ask about the expensive treatments, we did a study. Part of our study was also to working with a team of geneticists in southern Brazil. Southern Brazil is also a hub for for the clinical trials on genetic therapies, particularly MPS. And we followed, both doctors who recommend patients to the genetic trials, and then they take enzyme replacement therapies, which are the most expensive in the market, right? Those drugs, that's the orphan drugs, that if you get, like a drug for a treatment that cannot treat about 200,000 people or something like that, you get a monopoly on the patent, et cetera, et cetera. So it's a different model than the blockbuster model of drug development. And so Brazil became a hub for the testing of those enzyme replacement therapies, genetic therapies. And those are treatments that cost about $200,000 a year, right? So and it's very interesting that at a regional level, there were attempts to make the biotech company or the pharmaceutical industry who was carrying out the trials accountable to cost of treatment after the trial was over. Because that was the scandalous scenario. The trial ended, and then the pharmaceutical industry helped to create a patient association, paid a lawyer, and then they went to the courts and requested, the $200,000 treatments, right? So that's the extreme case. And in Rio Grande do Sul, they created some kind of ruling that to a certain extent binds the industry or the biotech company to pay for the treatment after the trial is over. So some of the companies left the state now. They went to other states. So it's a very migrant industry as well. And part of the clinical trial, that's the work of Adriana Petrina, that clinical trial becomes a marketing tool to create a market in the country. So you're absolutely right. That's part of the story. But both officials and scholars conflated that was equal to the phenomenon. And as we showed here, you could see that's the outlier of the phenomenon, I would say. It's a black box, the relationship that the Workers' Party had with the pharmaceutical industry. So incredible lobbying. The question of why there was no different kind of price negotiation during the Lula government, it's hard to understand. But it seems that they tried to play on both fronts. Let the poor get some kind of income, get out of terrible poverty, but also let the rich get richer. That's the contradiction, I think, of the Workers' Party rule in Brazil. And it finally defeated them.
Great, so we'll take a couple questions then. Maybe if you just introduce yourselves.
I'm Mindy Roseman. I'm at Yale Law School, and I really thank you for your provocative and counterintuitive arguments about the use of courts in realizing the right to health and its distributional effects. So I will confess that I was part of the initial wave in looking to see conceptually and empirically about the effects of the courts on health rights coming out in the wake of the TAC litigation and then subsequent litigation in South Africa, which seemed to at first acknowledge social rights and rights to health, and then took a step back and looking much more procedurally at as long as the government was reasonable. And so that kind of circumscribed the entry point, and the work you cite of Octavio Ferraz actually is published in a volume that I helped produce, which looked at sort of taking the ideological, I think, inspiration from maybe a Marxist tradition that rights were bourgeois, to look at the ways in which the middle class use the courts to consolidate what they think are entitlements to their citizenship and get the right to health. So what I would say, what you're describing, and I would love your impressions and reflections on it, are both certainly a response, like a systemic response. You point to a factor in, or a distinguishing factor, which is a a public advocate or a public defender accessibility in this jurisdiction, and maybe in all the jurisdictions where people have access to courts, that's a political commitment about redistributing and having a kind of social citizenship that can go into a dysfunctional system that's not delivering the social goods, right? And they can make the claims on the state that they're already entitled to. It's not terribly radical redistribution, but it is. In countries and jurisdictions where you don't have that, have you looked at the outcomes of similarly situated litigation? And would you say that that is, in the legal opportunity structure, the distinguishing factor?
We thought we might take a few questions at once, just to have the chance to have more of you get a word in. Others?
I'm Christina Talbert-Slagle. I know you know me. Okay. So I'm mindful that I'm not versed in this literature, and I think this question might sound a little bit naive, but I'm so curious. When you quoted the public defender, she said something about the social, mental, physical well-being that was a definition of health. And then I found that, you know, as you were talking and you made the case extremely compellingly, that health and the judicialization of health is really about a biomedical view of health and the pharmacalization of it. It's not a word that I often say. And I was curious about how the Constitution defines health and how this definition, I know that's a naive question for the lawyers in the room, but the WHO definition is social, mental, physical well-being. And I was curious about the constitutional definition, if there is one, and how this judicialization is defining health, and how the pharmaceutical piece of it is defining it in a biomedical way, and how all those things come together.
Yes, those are great questions. Thank you. Thank you so much. Yeah, the phenomenon that you mentioned, right, that the Comoros would say, right, from class struggle to class action, right, in South Africa. You know, but again, that speaks to a certain way of reading the phenomenon. We know that this was much more than that in South Africa. In South Africa, the judiciary had a different reading, right, of the collective. You know, there's the case, right, of 1996, right, the patient who wanted to have hemodialysis. You know, and the court said, no, we will not provide it to you, but right, you have to. So the system has to change, has to make it available to everyone locally, right? So it was a different kind of ruling. And it's very interesting, that question of the comparison, right? So the right to health in Brazil, South Africa, and India, for example, would be interesting. India, the high producer of generics, but availability, universal access to therapy is not necessarily, but then the right to food. It's very interesting what mobilizes people and how the judiciary navigates the state's view of its role to each kind of populations. The public defenders, you're absolutely right. They are political actors, and they take their work as political actors. Brazil has a sort of a fourth power, which is the public ministry. And this is the ministry that people can actually, people can access the public ministry and even file a lawsuit against the president or hold the state accountable. And so the public ministry is supposed to defend vulnerable peoples, particularly, indigenous people, descendants of Afro-Brazilians, descendants of slaves, but also the environment. And the public ministry has been a site where collective causes are waged. And they have a very conciliatory role. So, for example, patient associations of kids with genetic disorders, they go to the public ministry, and then the public ministry accesses local governments and mediates availability of treatments, et cetera, et cetera. It's very interesting, that role. But the public defenders, they have been very highly politicized in the state of Rio Grande do Sul. And it's very interesting that in São Paulo was the last country, the last state in the country that had free legal assistance. So judicialization, in my view, is intimately linked with access to justice. So the exception is not Rio Grande do Sul. The exception is São Paulo, right? So where people did not necessarily have that possibility of litigating, right? So the one thing that I just wrote my notes here, and I'm rambling a little bit, but hopefully these things will be connected, together in our conversation. AIDS changed the rule of the game completely. And we cannot pretend that ideas we had about policy and equality, or even economic ideas of the trickle-down effect, right? Oh, we make the technology in the north, and then in 15, 20 years, it will find its way into the south. That was changed completely. So why would we expect that people, knowing that there are technologies available, would not try to access them? And that, for me, is an absurdity that's built in many studies. For example, some Norwegian scholars, they go to Bolivia. They are filing a lawsuit for a drug that costs $800 rather than investing on maternal mortality. But hey, she is totally covered in Norway. And that treatment, which she needed, would be available for free through the healthcare system there. So there is a kind of like there's something assumed that the poor are social, that the healthcare system as it is, it's enough for the poor, And AIDS changed that radically. And I'm not making a judgment, that that's a good or bad thing, but the fact is that public health has been pharmaceuticalized. And the fact is that people are not waiting for the treatments to trickle down. They are mobilizing now. It's a complicated phenomenon because pharmaceuticalization creates its own kind of diseases, conditions. You're over-pharmaceuticalized. You're treating one side effect with something else. Maybe the treatment should be de-pharmaceuticalization, especially among the elderly, right, with polypharmacy phenomenon. But these are like new medical, social, legal realities that the subjects that we work with and the political subjects are wrestling with. So a lot of the first wave of studies of judicialization, they had a certain idea of the people or of society. And for them, the 90s, the HIV/AIDS, we had an immanent society. So activists were saying, see, those activists, they were fighting for the collective. It was not just for individuals, right? But it's kind of myopic to imagine, as Paula, the public defender says, people come here, they are individuals, but they are injured by public power. They are injured by the way there's no prevention in place, question of sanitation, not to mention not access to basic treatments or coordinated, therapeutics with social services involved, et cetera, et cetera. So in some ways, AIDS changed that game, I think, and the public defenders, and they are allied with this responsive judiciary. So how could this be politicized otherwise, right? It's always a key question, right? It's a key question. How could we? Many times the patient associations, their dream is to become a federal program. So the patient associations which are struggling with genetic disorders among their kids, they want to become a federal program because that's the program that worked. That's what made HIV/AIDS so successful, because it had a central purchase. They had public science involved that could reverse engineer drugs initially. That was the model. But then that fell apart. Then it became prey of your question of the pharmaceutical market without clear mechanisms of bargaining price and price reduction, et cetera, et cetera. But the idea, a lot of it is to become visible as a federal program. In some ways, I think Brazil presents these challenges that come with the universalization of access to care in the time where we have this expanding field of technological innovation with this overwhelming, as your work, Amy, reveals so powerfully, this political economy of pharmaceuticals, right? That has its own kind of cartography of markets and different regulatory price regimes, negotiations with countries diversely, and there's no way there's no mechanism in place that can hold that accountable, but federal governments, I would say. And the federal governments, they are so invested with finance, big capital, big pharma, even though if they are committed in principle to equity. So it's a different kind of political, legal, medical field on the ground, and my work tries to to raise this from the bottom up rather than from assumptions that we already know what the social is, what the population is, or what the right course of action is. The question that you ask about the concept, right, the right to health, the scope, the object of the right to health, that's a crucial one. What is the object of the right to health? I try to allude to the ruling of Celso de Mello, who was the Supreme Justice who ruled in favor of an AIDS patient who wanted an antiretroviral that was not part of the formulary, of the cluster of drugs that were available. And he ruled in favor of that patient. And I think that's the crucial question, right? Because the judiciary is still saying, even though it's not approved by the government or included officially in governmental lists, the state has the obligation to provide. So that's a critical, and that becomes an opening, of course, for the market to come in, et cetera, et cetera. But that's still the ruling of Celso de Mello that's used in all lawsuits, in all rulings by the judges. According to Mello, he said this, that the right to health is inconsequential if there are no programmatic responses. And the AIDS policy becomes the embodiment of what the state owes to the citizen. I think it's problematic. I think some groups, are trying to break them open, ask questions. What about sanitation? It's shameful, the situation in Brazil. Like some cities, some mega cities in the north and northeast of Brazil, 95% without sanitation, in cities, So, and then you have this high-tech world, right? So it's a complicated coexistence, and I think Zika, you could see that happening in the context of Zika as well. But I think the question of, there is some coding of the object of the right to health in the way the Supreme Court has ruled in favor of patients demanding treatments that are not part of protocols.
Great. Yeah.
It's fascinating as always, and I actually didn't know that you were really doing this kind of research, and so thank you for sharing it with us. Mm-hmm. First of all, I can't imagine the part of the world that I know best, which is the Middle East. I can't imagine this kind of scenario ever happening, because you'd have to have such a strong judiciary. You have to have lawyers who are activists who are wanting to take on these kinds of cases, which I think is sort of remarkable. And whether this is not just in Brazil but other parts of Latin America would be one question. The other thing is, you talked about patient groups and patient sort of advocacy groups, for example, for rare genetic diseases, and that sort of speaks to the issue of biosociality, that groups are forming around particular kinds of disease, groups. But are there many cases where just individuals assume that this is part of their right to go to court, to find a lawyer and do this? Are there many cases that are sort of individually led and agentive? I couldn't quite figure that out from the presentation, and that's interesting. If people are just saying, this is my right to do this, and I'm going to go and try to get the drug that I need. And then finally, beyond that, this was mostly about pharmaceuticals, but I started to think about things like, that aren't considered to be life-saving kinds of interventions, like your student, Alexander Edmonds, whose work on, say, plastic surgery, or those of us who are concerned about assisted reproductive technologies, that some of these are in the sort of realm of not life-saving, but they're quality of life kinds of technologies and interventions. Do people go to court for those kinds of things in Brazil? Because Brazil has a booming ART industry, for example. So, does this extend beyond the level of pharmaceuticals? Those are things that I was wondering about in your talk.
Yes.
Take one.
Hello. I'd like to pick up on that point, but also go back to the issue that you said about how the judicialization of, for example, medications is very different from that of sanitation. So I think it's probably fair to say that the Brazilian judicial system is fairly inefficient. But I would like to get your opinions on how that inefficiency, how to say it, enforces a selective pressure and what kind of, and this is related to the last set of questions, and how that inefficiency brings through certain types of issues versus others, and especially in the context of sanitation or the other social rights, which are very, you know, one could make the point, much more important than perhaps the right to medications and so forth.
Those are great questions. It's to your question, Marcia. Yes, people go to court to demand access to plastic surgery, for example. Some of they say, so then the question is it static or is it therapeutic? Right? So, and then the argument is made in terms of mental distress. So it's interesting. So it gets medicalized in that way. And I think some of those stories, they also pop up. So one of the, besides then the extreme case of which is very costly to the budgets, you know, the new therapies, like enzyme replacement therapies, there are also the scandalous cases. You know, we have people requesting a surgery, a trip to Miami, or to get a surgery in New York City, and they tend to be the stories that are picked up by the media, and based on those stories, the scandalous story, you know, that the main narrative, which somehow really creates this difficult public space for discussion, where people already are so polarized, pro or against, mostly against. So, and then it's unable to really understand this phenomenon on its complexity and diversity. The question that you ask about the lawyers and the advocacy of the groups, it's very interesting. There is already like an industry also of litigant lawyers, right? So like who professionalize in helping poor people, you know, access the courts. In our sample, it was not the dominant, but I would say some 20-25% of the cases were private lawyers. So there's already a niche for private lawyers to go there. I think overall what we see is this phenomenon also of democratization of society. So there was this, you know, this massive investment on a discursivity of rights. You know, certain jurisprudences were created, and I think people started to pick up. But unfortunately, they are not just fighting for the collective right or for the systemic change. You know, people have lives, they have complicated lives, they have interests. And I think that is very hard for us to reckon with. These are ambiguous subjects. They want something from the market. They want something from the state. Many times the recognition they want from the state is a commodity as well. So in some ways, over the years, by looking from the perspective of the various actors in this field, I started to think of judicialization as a para-infrastructure that to a certain extent helps all parties involved. The state prefers judicialization. Why would they not, given one case, try to reform a policy that would affect all patients with diabetes or all patients with who need a certain formula, like the girls here? They could have done that. So they prefer to contest, which is the question they ask about inefficiency, right? The state likes the judicialization because they can contest. And then they stop providing, and there's a new lawsuit that happens, right? The patients, in my view, they tend to be reluctant. It's almost like a last resort. By and large, they try to get it through administrative channels locally. Social workers say, go judicialize. Doctors say, judicialize, you need it, I want to treat you, right? And of course, in the spectrum of the rare diseases, genetic therapies, the doctors also want to experiment on the patients. The doctors feel, for decades I couldn't do anything, now there's this possibility, I want to see. And there is this tricky thing that without experimentation, what do we learn about new generations of therapies? So there is a large-scale experimentation going on, right? And acknowledged. Adriana Petrino, who happens to be my wife, my partner, she argues that what's missing in those trials that are used as mark is an informed contract, not just an informed consent. Because patients and families are giving value to these products, right? So maybe that would be one way to think within the more neoliberal frame, but there would be a way to think, what's owed to these patients, to these families, et cetera, et cetera. But I really think the immediate patient or the patient association uses judicialization to get access immediately. So it's like a meeting point of various actors in lieu of an attempt of any kind of infrastructural reform. The country's really falling apart infrastructurally, if you think, right? So in some ways, a more positive view of these individuals is that they carry structural violences, structural precariousness in their conditions and in their plight. Maybe a la Judy Butler, they are saying, infrastructure is about a commons. It's about conditions of livability. And to a certain extent, people do that, and they instantiate new social relations, temporary collectives. And again, the question, what does that amount to? It's a crucial one. And I totally agree with your question about the judicial system as being inefficient. And I think there is this dimension of the judiciary also wanting to affirm itself and gain a certain political voice, in the broader field of governance. So it helps as well on that level. It's very interesting. I was telling Amy today that for some reason last year we created in Brazil, we created in Princeton the Brazil Lab, those Afro-Brazilian studies. And one of our colleagues in Brazil, who is supporter of this initiative, said, João, if you really want to do something meaningful, you have to talk to these environmentalists. We're working in the Amazon on issues of really mapping deforestation, working towards conservation, working with vulnerable communities, riverbank communities. Without those communities, there can be no conservation, et cetera, et cetera. So we brought them to Princeton and to talk to us. And it's very interesting how they use also the public ministry and the judiciary to fight for conservation and protection of vulnerable communities. It's not a formula. Maybe now it will change. Now, maybe in the end, the judiciary will rule against them because it's inefficient. But in the meantime, they produced evidence on deforestation. They went to the public ministry, who then threatened large ranchers, take them to court, and they decided not to do. So there's something like there's an interstitial space that is created through this in judicialization or through judicialization that at least buys time, right? But absolutely, I don't think this is not equal to a systemic change, And I don't know if where we are now in Brazil, also in the United States of America, if that's even a possibility. If not, we are not cheating ourselves, being ever more myopic, right? If we do not need to think of other ways to intervene politically, maybe the scale is lower because there's such a massive dismantling taking place. And which tools do we have, to fight, if not that dismantling, other forms of mobilization that might, as Bergolla would say, to create some conditions of futurity.
That's a great place to end. So please join me in thanking Professor Biehl.
Thank you so much. Thank you. Thank you.